To welcome Professor Vasco Romão. Professor Romão is a professor of rheumatology in Lisbon, in Portugal.
Okay, there it is. Hello. Yeah, they're putting it up. Thank you, Coralie, thank you for the invitation. I extend my words that Professor Gules also said, that it is really a pleasure to be invited by patients. Also, Professor Gules already did most of my job, because a lot of the things that I were going to talk about are really new, and he already talked about them. But hopefully, thankfully, some of them are new also here today. So this is what I was proposed to present. Something that is now hopefully not so new, and it's going to change. It's this aspect of Sjögren syndrome or disease. In fact, we are likely turning the name of this disease to where it should have been from the beginning. And this is a very important process that is ongoing, where patients' voices are really being heard. And so these are some of the remarks that patients did, that patients, other doctors, family members get the idea or the impression that Sjögren is mostly a nuisance, a collection of symptoms, and that syndrome, the word syndrome, does not really convey the gravity of the disease, more like an ensemble of symptoms, and so like a flu-like syndrome, and so really not a disease itself. Whereas we can actually talk about diseases when we have a better understanding of the etiology and pathogenesis. And on this point, I should say that there are even some diseases that this is not even true, and we called it, we don't really understand that well as we do for Sjögren. And just to say an example is undifferentiated connective tissue disease, which is actually a mixture of symptoms, but where we cannot place them in a specific connective tissue disease. But whereas Sjögren is very specific, and so it is indeed a specific disease with specific features, both in terms of clinical features, immunological features, histological parameters, and so on. And so this international task force that is joining patient associations, clinicians all over the world, there's this undergoing process where there is a strong disagreement with the word syndrome. Also, changing to disease was rather well classified. Most people would agree to keep Sjögren, because then again, this is something that has been, especially in the States, overturned, so dropping the eponyms. But personally, I think it's a good idea to keep it. Also, it's even being discussed, should it's just Sjögren or Sjögrens, which is a thing in English, but not maybe in other disease, in other languages. At least in Portuguese, it's not a thing. But most probably, and this is, I think, is very important, to the primary, associated, secondary. I mean, in my view, there shouldn't be any. It's just Sjögren's, like there's no associated lupus or associated. There are some cases where you have two or even more diseases, but there's no reason for Sjögren to be secondary or associated or primary. It's just what it is. And so more to follow soon on this. And then also some new data that Professor Boetsma already presented at EULAR as well, highlighting a big genetic risk marker study in Sjögren's. Several markers that are here highlighted in red and blue, dark blue, were identified. And importantly, patients that have, as most of these diseases, this is not a monogenic disease, meaning that if you have some genes, you will have a higher risk. And this risk, if the highest 5% with this risk score have a 12-fold higher risk of developing Sjögren's. As we know, in absolute terms, this will still be a low risk for the person itself, but compared to the general population, it's high. So this model that is true for most autoimmune rheumatic diseases also applies in Sjögren's, and more we are learning about new risk factors that tell us about the pathology and pathogenesis of the disease itself. Then there are some things that we definitely as clinicians see in clinic, Patients also definitely identify this, which is, and now just focusing on the Zika features. There are, and this is very puzzling for us in clinic, and usually when we have fellows or from other specialties, we always tell them that this is very heterogeneous, the symptoms, and also the objective part, specifically in dryness. And so at this study that was presented in the International Symposium last year in Rome by the French group of Mariette, so they went and they analyzed patients without dryness in terms of symptoms, and they classified this as having a visual score of dryness below 3 out of 10, or objective dryness being normal, Schirmer's, and salivary flow. And what they saw is that patients without, so they were more or less 10% of patients did not have severe complaints of dryness, so up to a VAS of 3 out of 10. And these patients were usually younger. So they were younger, they were diagnosed faster, so they had a lower symptom to diagnosis duration. They were more frequently SSA positive, had lower fatigue levels, and had similar SDI and also similar organ involvement. Whereas, and this makes the thing even more complicated, patients without objective dryness, so with normal salivary flow or Schirmer tests, this was already around 20% of patients, so twice as much. But just going to the last part, which some of you might not see, but only 17 of these 113 had no subjective dryness. So these are patients that have subjective dryness, but have no no objective dryness. But these were also younger and had more frequently anti-SSA, had higher SDI levels, so higher systemic disease activity, had also more arthralgia and pain, generalized pain, similar fatigue and lower dryness scores. So this is, we don't understand why this is the case, but this is very important, and we see this in clinic, and this is also something very important to keep in mind in clinical trials, because then if we lump all these patients together, we might lose some signals. And also an important thing is what will happen if these patients will transition from one group to the other over time. My impression is that they do over time, especially because, as it's clear here, these patients are younger. So they are diagnosed early, at an earlier age, and then they develop. But we do have also some patients that never complain of dryness, even though they have all the markers and all that. So it's really, some things are still puzzling us. One thing that was already mentioned here by the work by Professor Fai's group in Newcastle, that is also for me very, very fascinating to be able to in line with this, to cluster patients into groups just based on 5 symptoms and a few questions. And so in terms of symptom burden, lower, high, and also if it's dryness or pain dominant with fatigue. And this is not only based on clinical features, this is also based on symptom burden. So patients with a high symptom burden have a much higher decline in quality of life. And also they have differences in specific markers, biological markers, and also, for instance, the patients with dryness dominant with fatigue have lower salivary flow scores, had lower Schirmer scores, and also the patients with low symptom burden had less lymphopenia. And, for instance, patients with pain dominant with fatigue had less SSA or SSB proportion in terms of as a group. And this is also confirmed in terms of transcriptomic signature. So there's a biological correlate here. It's not just symptoms, which is, in a way, it tells us something that the symptoms may actually be related to the pathogenesis of the disease. And as also shown here, we can get some differences in some groups when we reanalyze some trials, the Joker trial. So this group, high symptom burden, had an improvement on with hydroxychloroquine, even though all the other groups did not, and the whole trial was very negative. And also the same when reanalyzing the Tractis rituximab trial, another group, so the dryness dominant with fatigue had a difference. Also, the whole trial was negative. So this is really an important part of the research now, is defining which clusters, and I think this really replicates what we see in clinic, that this is not a homogeneous disease, even though the criteria are more or less homogeneous. An interesting study presented at EULAR by Groningen's group analyzed interferon signature in vaginal tissue of women who complained of vaginal dryness. And they were able to show, compared to controls who had no dryness, that the interferon stimulated genes, so the genes that are involved or are modulated by interferon, which is very important, we know, in Sjögren's, were upraised, and this was seen not only here on the genes themselves, but also at the tissue level. At the tissue level with a protein that it's induced by interferon, and this does also give some information regarding a very relevant syndrome, most of the times undervalued by clinicians or under-assessed. So this is also very interesting. It's not yet published, but hopefully it soon will be. Another profile is patients that only have a subunit of anti-SSA, so anti-Rho 52 isolated patients. A poster by the Italian group presented a sub-analysis of these patients, and they found that these patients had a milder tissue focal inflammation, so they had lower focus scores, low prevalence of lymphadenopathy, lower prevalence of anti-La, and lower hyperglobulinemia. However, they had a higher risk of fibrotic changes, especially fibrotic lung disease, and a higher prevalence of concomitant disorders such as primary biliary cholangitis. So we don't know what this is, but again, this is something we see in clinical practice. And this is all very concordant with this cluster definition, is if we define the clusters not in terms of symptoms, but start from the molecular patterns. And the PRECISE-EDS consortium defined this and found 4 clusters, mainly cluster 1, which is maybe the more inflamed with higher interferon signatures, cluster 2, which is more like a healthy-like profile and the lower S-di, and then cluster 3 or 4, which are kind of intermediate. And what is interesting to see is that, for instance, S-di is different between the groups. Of course, here the numbers are very high, even though the differences are not. Hyperglobulinemia, for instance, is also much lower in cluster 4 and 2, for instance. And here below we have anti-SSB and rheumatoid factor, which are also much lower in cluster 2. And again, these are all patients with so clear diagnosis of Sjögren's. And also, if we reanalyze some rituximab data, so we can see that, for instance, in cluster 3, 100% of patients of the TRACTIS trial responded to rituximab in this cluster. So when we get 100% data, that raises our attention, because either it's a mistake or it's something very promising. And so as a whole, again, we are starting to see that reanalyzing trials that are overall negative maybe that's the way to go, and that's why we see some patients really benefit and others not so much. A recent trial, a recent study that was published focused on another very important thing, which is the so-called seronegative Sjögren. So these are patients that do not have anti-SSA or anti-SSB, but they really have all and several features that are very typical of Sjögren's, including positive lip biopsies. And so what they found here is that they found 12 new autoantibody specificities, nine of which were commonly found also in this seronegative Sjögren group. And this binding to at least one of these antigen was identified in about half of the seronegative patients. And so this means that we could, at least with these antigens, and this was validated in more than one cohort, find at least half of these so-called seronegative patients, because sometimes patients really do look like Sjögren's, and sometimes we establish the diagnosis without antibodies. But without antibodies, without any features of the salivary glands, without any immunological changes, it is difficult to make the diagnosis. And even though patients may have these symptoms for other reasons, and there are many reasons to have pain and fatigue and Sicca syndrome. So these are promising data, and let's see if at least some of these autoantibodies can find their way to clinical practice. So we already heard about the harmonics data with a lot of patients with lymphoma from a fully harmonized data set. And so this data focus on the presence of cryoglobulinemia and salivary gland swelling as the major factors associated with future lymphoma. And we will hear more of this soon in a paper. A very interesting study that was published a couple of years ago from Professor Mariette's group. They studied 24 patients who had lymphoma. And they, instead of doing a parotid biopsy or a lymph node biopsy, which is sometimes difficult or impossible because the nodes are not accessible, they did a more common minor salivary gland biopsy. And in half of those cases, they could reveal the lymphoma there. So, and in 10 of these 13 cases, it was the only site that they could do the diagnosis in. And so this is very important. So in most of these cases were mild lymphomas, and all of them had a positive biopsy, so this is not surprising. And also importantly, the patients who had lymphoma and had a positive biopsy or not had similar clinical features. So it was not the biopsy that gave us, not the clinical features that gave us the diagnosis, but the diagnosis could be done at least partially with this easily accessible technique. And so this is the message that they have. So this is one of the important things that patients sometimes ask us. So I already have the diagnosis. Do I really need the biopsy? In Lisbon, we offer and perform the biopsy to every patient with a diagnosis or suspicion of a diagnosis for several reasons. One of them is listed here. So sometimes the patient comes to us and it's the first diagnosis, or they have already had the diagnosis for 10 years. But then maybe 10 years from then, we will have a doubt. And so it will be very important to have a baseline to compare to. This is one reason. The other reason is that sometimes we find by chance, is not common, but we can find a mild lymphoma there, and also diseases. So, for instance, sarcoidosis can come up, and just recently I had a case like that, which then mixed what is going on here. But usually, and being in a setting where we are used to doing it, it is a safe technique. And I'm just sharing a case of a patient of ours, a 64-year-old woman that in 2015 complained with dry eyes and dry mouth, and then a year later, very important body weight loss, persistent parotid swelling in a couple of years later, and then purpura, so vasculitis of the skin, and arthritis. Interestingly, she was anti-Rho52 positive, isolated, and anti-centromere positive. And she had a biopsy done, this was in France, in 2016, with a positive, which was very positive. Then she came to Portugal, well, after she retired, and she had an ultrasound, which was also very revealing of Sjögren's. She had a low Schirmer and a very low salivary flow. And then before coming to Portugal, because she was having this persistent parotid, left parotid swelling, she did a biopsy of the parotid, and they diagnosed with marginal zone mild lymphoma. And so she did rituximab. This was under the hematology, and she had a good response. But then she comes back a year later with persistent swelling. So not persistent, but it came back. And the hematologist didn't know if it were Sjögren's or mild lymphoma, and so we were discussing what is it. And what we do, based on this study, is we did a minor salivary gland biopsy, because in our setting it is not easy to do the parotid biopsy. And then the minor cerebral gland biopsy confirmed these features of mild lymphoma, both histopathologically, also from the molecular point of view. And so we sent her to the Oncology Institute, and she did rituximab plus chemotherapy, and she has been ever since in remission of the lymphoma. And so this is a practical example of how a paper can then change our clinical practice back home. Another technique that... 3 minutes, okay. No problem, because most of the studies have already been spoken. So this has been also addressed. So the group in Italy undergoing under ultrasound-guided core biopsies. And so this has been shown to be effective in diagnosing both lymphocytoadenitis and also lymphoma, and has been safe and well tolerated by patients. And this is a not so spoken technique, which is elastography. So it evaluates the stiffness of the glands. It's usually used for liver disease. And a study from Portugal, from the Queen group, found that these patients had increased stiffness in the parotids and salivary glands, which is associated with this ultrasound score, but not with disease duration. So it means fibrosis, probably. I'm going to skip this part, which is on lymphoma. Also, STAR was already presented, so this is a very promising tool, and that is being assessed in the Necessity Consortium. And I'm going to focus on treatment. So we already, they have been published for a couple of years, even though the final publication was only last year. But the EULAR recommendations are guiding us for oral symptoms, ocular symptoms, and also specific gland organ involvement. So treatment is still not uniform, and it's based on which organ is involved. But these recommendations are mostly based on low-grade evidence and expert opinion. At the time, there weren't any positive Sjögren trials. Just a quick mention of something that is also not so frequently spoken, which is and of course we need the oral medicine experts here to do this. And in our case, we have a collaboration with the oral medicine where they do irrigation of the parotid glands with saline and glucocorticoids. And this is a procedure that can be repeated up a few weeks. And it improves in about 10% the symptoms and also the objective dryness. And this is for patients with very severe dryness where we cannot offer much else. And so 10%, I think it's already good. And more irrigations had a more pronounced reduction in symptoms. Another point focused by Professor Boetsma in EULAR is that only 20 to 30% are eligible for trials. So this is a very big issue. This is being overcome by the trials including patients with low SDIs. But still, I mean, then you see how many patients are left out. But we are indeed seeing the light at the end of the tunnel. And after a very dark age, we started having positive or somewhat positive trials. And now we have definite positive trials, which are already presented here. So the repurposed trial with leflunomide was a very small trial, but still very positive. And this was very exciting. The scalimab trial, the phase 2 trial, was also positive with a difference in SDI, but no differences in ESPRI, unfortunately. And the ianalumab trial was also positive, and these trials are all in phase 3 as we speak. And just in EULAR, in the last couple of slides, 2 new trials were presented. So the 2 trials on the dazodalibep drug, which will target CD40 ligand. And these trials were very exciting because they had 2 populations and both met their primary endpoints. And so one of them was the systemic disease activity, and then this population, which is very common in clinical practice, had a huge effect on ESPRI, which was not seen up until now, at least with this degree. And finally, telitacicept, so I have to read this slowly, which is a BLyS-APRIL inhibitor, and also had, this was a small study, improvements in SDI, ESPRI not so much, but then the very interesting increase in salivary flow and in Schirmer, which is something that does not change much, at least in our experience. Here in the big dose, in 240, they had an increase in Schirmers. So these are the promising and exciting results, and thanks again for inviting me for attention.
Thank you so much. Any question? Yeah.
Are the genetic markers bared by the X chromosome mostly? And those genetic markers, are they correlated to any stratification?
So these genetic markers, they are not all, mostly they are not related to the X chromosome. There is another mechanism, which I don't think it's well studied in Sjögren's, but it is in lupus, which is the inactivation of the X chromosome. But these are mostly identifying risk to develop Sjögren's. So they get hundreds of thousands of patients, or at least tens of thousands of patients. We usually have to have a lot of patients, very big numbers, and they get markers that are very, very overexpressed compared to people that do not have this disease. And then you have to see the markers as a whole. So it's very difficult to then stratify per prognosis and so on. So this is mostly, this highlights the nature of the disease. Of course, if we get a big signal of a gene, we're going to look, what does this gene do? And then if we see if it's very important for a specific cell, T cells or B cells, then maybe we get into it. But usually it doesn't allow us to then stratify, because we're already operating under such big numbers that it's a hard thing technically to do. But it's very important to understand more about the disease and also eventually treatments.
Thank you. Thank you, Professor Romão.
Thanks.